Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. My guest today is Dr. Scott Morin, a pulmonologist at SMHC Pulmonary Medicine. Dr. Morin is with us to talk about chronic obstructive pulmonary disease, more commonly referred to as COPD. Dr. Morin, welcome to the show.
Thanks for having me.
And I guess a logical first question would be, what is a pulmonologist?
Well, I'm an adult pulmonologist, meaning I specialize in treating adults for different lung diseases. Primarily in this area, we see a lot of patients with COPD, asthma, other sorts of intrinsic lung disease. I also treat people for obstructive sleep apnea and a variety of sleep disorders.
Now, when you say in this area, are you talking about things that you would see in Southern Maine that you wouldn't see maybe in Boston?
Well, I'd say in my career, I've sort of taken a special interest in COPD in particular because it's such a common disease. It's the third leading cause of death in the United States. And in Southern Maine, there is a high prevalence of COPD.
And maybe for those who don't know, describe what COPD is.
COPD is an acronym, stands for Chronic Obstructive Pulmonary Disease. It's typically a smoking-related disease that results in loss of lung function. And typically, it's a progressive disease so that it can start out in a very mild form and then get more severe over time. And the reason it can become debilitating is it can result in severe shortness of breath, low oxygen levels, multiple hospitalizations due to recurrent lung infections and lung inflammation. And because this area historically has had such a high rate of smokers, it has a high prevalence of COPD. So one of the things that we've tried to do is increase sort of the awareness in the community that COPD is highly prevalent, increase this awareness so that primary care physicians are aware of it, can initiate the diagnostic workup and treatment. We aim to reduce hospitalizations and ultimately, hopefully, see better outcomes with less illness.
Do you ever see cases of COPD in patients who don't smoke?
Yeah, it's a smaller percentage. Usually there's some exposure, either secondhand smoke, occupational exposure, especially in this area with the different mill work, and so exposure to different occupational fumes or chemicals can increase the risk of COPD. It's also, there's genetic components to it, so it tends to run in families. So there, occasionally when I see somebody who has COPD and there's a strong family history, especially if they have a form of COPD called emphysema, which is a type of COPD that results in destruction of lung tissue. There's a specific genetic disorder called alpha-1 antitrypsin deficiency that we'll look for in certain people.
So talk a little bit about the symptoms. You've already mentioned shortness of breath.
People should really think about COPD, doctors and patients, and anybody over the age of 40 who has a long-term smoking history, who has sort of the slow onset of cough, shortness of breath, wheeze, would be the most common symptoms.
So if someone is diagnosed with COPD, what sort of prognosis can you look forward to? I mean, obviously, quitting smoking would be a no-brainer, but what can they do to improve the situation?
Yeah, the treatment hinges on smoking cessation for active smokers. And the reason for that is because there's pretty good data that's the number one thing that will preserve lung function over time. There was a study in the 80s called the Lung Health Study where they actually followed patients over time, non-smokers, active smokers, people that had smoked and then stopped smoking. And what they found was that in general, people that develop COPD, when they quit smoking, the loss of lung function matched that of a non-smoker. Meaning, if you have COPD and you're losing lung function quickly over time, if you can quit smoking, that sort of halts the progression of the disease. that's not a universal truth. We know that there are some people that will have progressive disease even when they quit smoking, but that's the number one thing, because lung function is the most important surrogate for outcomes, meaning it seems to match up that as you lose lung function, the severity of the disease gets worse, and there's more incidence of hospitalizations, early death, worse symptoms. So we really emphasize recognizing the disease in the early stages, because an intervention like quitting smoking can save lives. If you diagnose it in the very early stages, somebody may never have significant symptoms.
Can you explain a little bit about lung function and how smoking affects it?
Well, COPD is really characterized by inflammation, and it's actually inflammation that occurs inside the lungs and outside the lungs. But what really causes people to become debilitated and lose lung function is that the inflammation inside the airways results in accumulation of mucus and inflammatory debris. It also can cause the muscles that surround the airways to sort of hypertrophy and become abnormally sort of spastic in a certain sense, and actually causing narrowing of the airways. So air, as it travels in and out of the airways, the airflow becomes slower or obstructed. And so you look for things that triggers that inflammation, and cigarette smoke is the most important trigger. The other form, I should go back and say that, COPD is really characterized by three things. One is emphysema. That actually results in not only narrowing of the airways, but destruction of actual lung tissue. And cigarette smoke is the, again, number one trigger for emphysema. There's chronic bronchitis, which is characterized by multiple bouts of bronchitis. People with chronic bronchitis oftentimes have a daily cough, daily sputum production, and that's really defined as more inflammation within the airways themselves and not the sort of outside peripheral lung tissue. The other thing that I do think about, especially in non-smokers, is asthma that goes unrecognized for years can actually result in permanent loss of lung function that when you look at a breathing test, for instance, will have the same pattern as somebody that has COPD.
Well, let's take a typical patient, maybe a 60-year-old man who is a smoker, who comes into your office. What's the first thing that you'll do when you meet that patient?
I think the number one thing you want to do is make sure you have the right diagnosis, because you never want to label somebody as having COPD unless you prove it. That has a lot of implications. I mean, a lot of people don't want there's a certain stigma with saying you have COPD. It can make a difference if you're applying for life insurance and all kinds of things. So you want to make sure you have the right diagnosis. And in fact, there is a lot of data. There's a number of studies that show we don't do a very good job of proving that people have COPD. Doctors presume one has it based on symptoms and a smoking history, when in fact people who are active smokers often have similar symptoms to those with COPD, but when you actually measure their lung function, it's normal. So in your scenario, the first thing I'd do is probably take a complete history. You'd want to get a chest x-ray. There are other types of lung disease that are less common but can also produce similar symptoms, so a chest x-ray would be important. And I would also do a breathing test called spirometry. And spirometry is a simple, non-invasive test where you actually breathe into a spirometer and it measures airflow and lung volume. So we can tell how much air you're breathing out, and we can also measure the velocity of that airflow. And that produces certain patterns of data that are characteristic of either normal lung function or something called obstructive lung disease. Incidentally, asthma is defined as having reversible obstructive lung disease, whereas COPD is fixed obstructive lung disease. So this test, the spirometry test that we do, if we suspect COPD and we have you breathe into a spirometer and you do the test correctly and it shows that you have an obstructive lung defect, We would then give you albuterol, which is an inhaled medicine that helps to open up the airways. And if you had asthma, if we repeat the spirometry test, your lung function should normalize. If you have COPD, it might show some improvement, but won't completely improve to normal. So that really is the number one test to confirm the diagnosis of COPD. And then there's some other testing that, depending on the situation, we might do, whether it be certain types of blood work. Sometimes we like to measure oxygen levels both at rest and walking around. So there is a bit more to the workup, but the number one thing I would think of in the scenario you describe is a complete history, occupational history especially, smoking cessation, smoking history both with you and whoever you're living with. Any symptoms that would be characteristic of asthma, whether you have environmental allergies is important. A chest x-ray and the breathing test. That's a good start.
So it sounds like there's a lot of testing involved. Have you ever run across a case that is difficult to diagnose?
No, but I would say that the reason to do testing is there's always surprises. I mean, I've met people who have daily cough, shortness of breath, they smoke heavily, you test their lung function, it's normal. And so then they might fit the profile of somebody with COPD, but they really don't have the diagnosis. It's not a difficult disease to diagnose. You have to be thorough and you have to actually confirm it.
And what sort of reactions do you get when you have to diagnose somebody with COPD? I mean, is there hope with that diagnosis?
I try to provide a lot of education regarding COPD. I actually approach COPD with a fair amount of optimism because there are interventions that work. We can make people feel better. We know that for the most part, we can do things that helps halt the progression of the disease. So I think the one thing that I try to show people is what their lung function looks like, what it means. So if you have a breathing test that shows you have very mild COPD, then we got a lot of a lot of wiggle room here, so to speak. And you can take somebody with normal lung function and remove one lung. They've done to do that for lung cancer. They'll take out an entire lung, and if the other lung is normal, you can live a fairly normal life. And we're born with a lot of redundant lung tissue. So you can actually lose up to really 50% of lung function. In fact, most people don't require oxygen until they have about 40% of normal of lung function. So I tell people that the good news is that if you have very mild disease, you're going to live a normal life if we do things correctly. People with more severe disease, there's still room for optimism because there are treatments that work, but I try to impress upon people with more severe disease, especially if they're still smoking, that now is the time to quit. So I wouldn't say that people necessarily should feel defeated or discouraged. It just means that we have information here that shows us we need to do something.
You're listening to Southern Maine Healthcare's Medically Speaking with Robert Erickson. My guest today is Dr. Scott Morin, pulmonologist at SMHC Pulmonary Medicine.
Not every boo-boo is an emergency, but it still feels like one. That's why Southern Maine Healthcare offers walk-in care. You'll find compassionate care at wonderfully convenient locations. Open 7 days a week, no appointment necessary. For those times when the unexpected happens, or you're just not feeling great, look for the orange ball as your sign of the best walk-in care. In Kennebunk, Saco, Waterboro, and Sanford, Southern Maine Healthcare, a member of Maine Health.
And we're back talking with Dr. Scott Morin, pulmonologist at SMHC Pulmonary Medicine. Now, you've already mentioned about the prevalence in southern Maine. What about the United States as a whole?
Yeah, lower respiratory diseases, I think, is sort of how it's classified when you look at mortality data. But COPD represents a large chunk of that data. is increasing in mortality rate. So it used to be the fourth leading cause of death. The most recent data suggests it's now the third leading cause of death. It's, I believe, the number 2 or 3 cause of hospitalizations and rehospitalizations. It's a big deal, and the thing is it sort of falls under the radar because the symptoms can occur very slowly over time, and so if something happens very quickly, we sort of develop an increased recognition of it. If people just sort of learn to live with slowly smoldering symptoms that are insidiously getting worse over time, it's very easy not to recognize it until the disease is actually advanced. So yeah, it's an important disease that we need to recognize and diagnose early, and it will have, if we can do that, we should be helping a large part of the population.
Now, you did mention that you can get it other ways besides smoking. What about pollution, like air pollution in large cities like Los Angeles and New York?
Yeah, airways disease in general will increase in areas where there's large pollution and ozone levels, especially in the summer. Even with normal lung function and no lung disease, the environmental pollutants can have an effect on lung function. In this area, we're primarily dealing with more of a suburban or rural population. So for my purposes, it's primarily occupational, household exposures, and smoking history.
So talk a little bit about some of the treatments that you would prescribe and maybe some of the side effects from those treatments.
Side effects and cost. I would say the cost of inhaled medications is the number one barrier to people getting effective treatment. I focus on 5 things when it comes to treatment. And number one, we already talked about, and that's getting people to quit smoking. So that usually involves counseling, education, perhaps medication to get people to quit. So we talk about that. The number 2 thing is using inhaled medications to help open up the airways, to help the airflow velocity increase, and that usually results in improved symptoms such as shortness of breath. Inhaled medications can be short-acting, like albuterol or ipratropium, which are medicines that you would breathe in through an inhaler. It takes about 20 minutes for the medicine to take effect, and it'll last for about 4 hours. And somebody with mild COPD who just has occasional shortness of breath or wheezing might use that medicine sort of as needed. And for people that have more advanced disease, they might have persistent shortness of breath that lasts when they wake up and lasts throughout the day. And in those patients, I'll typically prescribe a trial of a long-acting bronchodilator, something that can be taken once or twice a day, and there are several choices that are available to us. The biggest thing with inhaled medications is assessing people's response to treatment, because when it comes to inhaled bronchodilators, I call them, there's a wide variability of treatment response. In other words, some people with COPD actually have a big improvement in their lung function with the inhaled medicines. Some people have no improvement whatsoever. And the same with people's symptoms. Some people really feel a great benefit from the treatment, and other people don't. So the number one thing is reassessing people's symptoms when you prescribe these medicines, because they can be expensive and they can have side effects. Each side effect is really dependent on the individual medicine, but common side effects can include tremors or headaches, perhaps even heart arrhythmias if you really overdid some of these medicines. Nausea, difficulty urinating can be associated with a certain class of inhaled medicine. So you want to make sure that it's A, helping, and B, they're not having side effects. So that's number 2. Number 3 is you always want to make sure that somebody, especially with advanced COPD, doesn't need oxygen. So typically I'll measure their oxygen levels with a little finger probe at rest, and then even with a simple exercise test where they're walking for 6 minutes and measure their oxygen levels. The number 4 thing is vaccinations. We typically recommend influenza and pneumococcal vaccinations in people with COPD. Number 5, and what I consider the most important recommendation for people with persistent shortness of breath and COPD, is a program called pulmonary rehabilitation, which is both a educational and a program that typically meets 2 times a week over several weeks. The program that I'm involved with is run by a nurse, an exercise physiologist, and a respiratory therapist. And the reason why I say it's the most important is the data suggests that it's the most important. And when you look at shortness of breath scores and quality of life scores, people have better outcomes with pulmonary rehabilitation than they do with the inhaled medicines. So, and it's also been shown, just like the inhaled medicines, to decrease in the rate of hospitalization. There is even some data to suggest pulmonary rehab can make people live longer with COPD. So it's really important. It's not easy. Transportation to a rehab facility twice a week can be a real challenge for people in this area. But like most things, the things that have the best outcome are oftentimes the most challenging to get done. So, but that is that's the one thing that I'll recommend to people who have persistent shortness of breath on a daily basis.
So can you tell us a little bit about pulmonary rehab and what happens there?
So what pulmonary rehab or pulmonary rehabilitation will typically start with an intake where the director of the program will look at the lung function. They'll do a simple exercise test to see what happens with the heart rate and oxygen levels with exercise. And it's a personalized program. So they put you through different sort of exercises, whether that be on a treadmill or a bicycle or even a stair climb or different exercise equipment in a monitored setting where both the oxygen levels, heart rate, breathing rate is all monitored. But a large part of it is really education. You can actually improve techniques with breathing that reduce what's a phenomenon called air trapping that occurs in people with COPD, where it's so difficult to get the air out of their lungs, they sort of trap air in their chest. It's almost like if you're blowing up a balloon and keep blowing it up without letting the air out, the balloon gets bigger and bigger and more distended. And if that's happening in your chest, in your thorax, it can be very difficult to breathe. And so there are actually breathing techniques that can be taught to reduce the amount of air trapping, which then increases one's exercise capacity. That can't be taught in a single visit. It's usually something that gets taught over a course of a few weeks. So that's really one of the things that pulmonary rehab will emphasize is strategies to improve your breathing. There's also a nutritional component where people's diet can be tailored to improve their shortness of breath and general health. We worry about people with COPD who are grossly underweight and also people who are very overweight. So that can be a teaching point. One of the things that pulmonary rehab does very well is teach people how to use their inhalers correctly and when to use them. And we know that one of the biggest or significant causes of people getting admitted to the hospital or suffering from COPD is they're not using their inhalers correctly. In fact, a lot of primary care physicians or caregivers in the primary care community don't actually know how to use the inhalers. They prescribe them, the patient goes to the pharmacy and picks them up, and then they bring them home and they're on their own. So that's a really important thing, is not only how to use them, but when to use them. So those are some of the broad strokes about what the program offers. And depending on the severity of the COPD, you might do more or less sessions. So usually private insurers and Medicare will at least pay for, Medicare will will pay for 72 sessions in total, but usually we like to start with 18 sessions for people that are sort of a low-risk patient that would benefit from it, but they don't have very advanced or severe disease. And that usually gives them, after they've completed the program, they might have their own exercise routine. They can even, there's at our particular hospital, we have a program set up where the patients can keep using the lab with a monthly fee. It's not the same monitored setting where you're under the direct supervision of a respiratory therapist or exercise physiologist, but it's sort of attended by people that oversee the program in case they need help.
And how can people get info about the program that you have at SMHC?
I think if you want to know more about the pulmonary rehabilitation program at Southern Maine Healthcare, Catherine Murdo would be the number one resource. She's a nurse. She runs a pulmonary rehab program. She also helps sponsor the Better Breathers Club, which is sort of connected to the pulmonary rehab program, but it's a resource, a group of people with COPD or similar lung diseases, because one of the things that, especially in this area, I really have come to recognize is that COPD can be a very isolating disease. We live in a rural area. It's often hard for people to get out of their house if they can't breathe. And the isolation can result in depression, a sedentary lifestyle, and that sort of increases the debilitative effects of COPD. And so having sort of an outreach program can be really important for people just to meet other people with the disease. The Better Breathers Club typically sponsors different speakers who come in and talk about a certain aspect of COPD. So, I think one of the nice things about the pulmonary rehabilitation program here is it offers so many different benefits to a patient: social and mood, self-esteem, exercise capacity, improved COPD symptoms. It's an empowering experience. And I always tell people that when I talk to patients about how we're going to treat their COPD, I said the inhaled medicines may help you. In fact, I always ask people how the inhaled medicines are working because I get all kinds of responses. Pulmonary rehab, I've almost never had a patient come back to me and said that didn't help at all, or that wasn't worth it. It's almost universal where people will come back and tell me, I feel much better. And that I just don't get that same response with other interventions like the inhaled medicines. So, yeah, it's something that I really encourage people to do.
So if someone wants to find out about the different programs that you have or the Better Breathers Club, how do they go about doing that?
If they don't have a pulmonologist like myself, they simply should just ask their primary care physician. That the primary care physicians can initiate a referral. You don't need to see a specialist to get into the pulmonary rehab program. You do need to have a breathing test to confirm the diagnosis in order for the insurance companies to pay for the program. You have to have the diagnosis confirmed. But it's a really simple referral. The primary care physician just calls over to the lab and makes the referral. So right now, occasionally there'll be a little bit of a wait list. So a patient may have to wait a few weeks to get into the program. That's variable. Some people can start the next week. Other people have to wait a couple weeks. It just depends on the volume or the particular time of year. But we haven't had yet, knock on wood, any issues with access. Typically, patients that want to participate can participate.
And I think, as always, if anybody wants more information about any of these programs, they can go to smhc.org. Well, Dr. Morin, it's been great having you on the show.
Oh, it's a pleasure to be here. Thanks for having me.
Well, we've run out of time for this week. My guest today has been Dr. Scott Morin, a pulmonologist at SMHC Pulmonary Medicine. Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities, brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.